Very exciting stuff coming out in the next few months from Eduardo Arnitua in Spain, who did studies with molar extraction spaces, just putting in the fibrin from his PRGF, and just the fibrin by itself against site with grafted particulate. And what he's finding is he's getting more bone, he's getting more keratinized tissue in 3 or 4 months with his biopsies. Wow. So it'll be very exciting if what we see is the fibrin is all you really need in these sites, because at $10, you're getting the body's own blood.
Absolutely.
The PRGF inside the socket and the fibrin on top, he's finding he's getting great crest-to-crest healing. Now, one of the real interesting aspects of this is that sometimes going back and being able to put the tissue in increases the thickness of your tissue for your aesthetic zone. What do you do about fenestrations when you get those little fenestrations?
Can I just go back to one thing on the grafting? Okay. See, a lot of people think you have to pack it like an amalgam into the socket, and that's what problem. No matter what graft material you use, you need to have blood come through the graft. You should see it be pink, and then you need to stabilize the graft. It's just like an implant. You can't have it be moving around everywhere, and that's important. I use a different combination of material than I think you guys do, and we've gone in and gotten good bone cores. I make what we call a marshmallow. I take the peptin gel, it's called Flow, and peptin particulate, P15, and mix it together like a marshmallow. Mm-hmm. We put it in. If we can't get closure, we just take a piece of collar tape and exit, and we're getting hard bone, keratinized tissue, hard bone. I have it on the pictures. In 120 days. Fantastic. So but everybody has their combinations. You know, what works.
That work.
Huh?
As long as the formulas work.
I mean, you can ask a French chef that makes an onion soup. He's got one formula and it's delicious, and somebody else does something different. So you just have to kind of play around with it, and don't 100% time. You know, believe that each manufacturer that makes these things, say it jumps out of the bottle and grows it overnight. So it's really clinician dependent. That's one thing. Now you ask about fenestrations, and anyhow, when we take out a tooth, the first thing I do is I go in with perio curettes, and I place my finger right up into the facial part. And I drag that curette right up against the facial bone. If my finger moves, that means there's a hole. Then I have to make a subjective guess. It's not very scientific because I'm not flapping it at that point. What is the diameter of that hole? If I can go around and just in my mind guess that it's 4 millimeters or less, I'm not going to flap it. And again, I'm going to keep my implant palatable to that facial wall, so there will be a little space. So if I want to put a gel in, no matter what you use, something that, again, that will be moved without pressure when you insert the implant to seal that. Now, if we have a big fenestration, where you have a big V cleft in your absence of facial bone, in my opinion, I graft that first. I don't, because I always look to see, what if it doesn't work? And I place the implant, and it doesn't work at the same time, then I've lost two things. I've lost the graft, I lost the implant. So I'd prefer to graft those if they're absence of facial bone. I know people show membranes and putting all the stuff over it, and it works.
I think we have 3 people who've done a lot of these things, and this is important that I just pause for a second. I happen to think all 3 of us would agree with that.
Yes.
And I especially think we would agree in patients with a thin scallop biotype. I know that would be a case where you would be block grafting the facial plate and packing inside the socket with bone, almost like an interposition. Tissue always over the top?
Yes.
Tissue over the top?
Yep.
You know, it's amazing. You can sit here in a room with, again, 2 of really the biggest guys in the business on this and have some consensus, I think, is outstanding. Now, I know in just a moment we're going to have the opportunity of getting a few-minute lecture out of this man right here, who's going to show you how he handles it, just on a few cases, and to describe it. We're going to really appreciate it. I thank you both for your time. We're going to see Mike in just a few minutes as well.
Thank you. Okay.
Jack,
thank you.
Pleasure, and thanks so much
for being here. It's always an honor to be with you, and we appreciate your knowledge and sharing with us, because you guys are the future. I'm the old guy here. And, you know, like I said, and maybe I'll say it on the tape, I'll say it tomorrow, following these guys is like me and Zsa Zsa Gabor's ninth husband. We know what to do, but we don't know how to make it interesting. So,
Jack, you're a pioneer, though. You're a true pioneer. We appreciate what you've done for the profession.
Well, we appreciate you know, you guys are a result of the students becoming better than the teachers. And so if you want to look at the success of a teacher, that's the success of a teacher, when the students become better.
Well, we only stand up higher because we're standing on your shoulders. We thank you so much for your time.
Thank you.
From Dental XP TV here in Chicago, we'll see you guys soon.